to come and share with you. I thought I'd take the opportunity to use this. Initially, the issue that I was asked about was around our assessment and the involvement of that with carers. And I thought it would be useful just to share with you some work we've done already in how we're trying to develop our services better, and also then some work that's in progress now, because what we're trying to do is to improve both access and the responses we give for any adults who do require access to either health or social care support in the community. We're in one respect quite fortunate in Jersey that we already have an integrated system. Although what I recognise is, as an integrated system, for some years we've had too many silos within that system. What I'd like to do is just share with you a couple of things that have happened that have started to fall into place, and along with that, as I say, some things that are going to happen over the next 12-15 months. The first main issue in regards to assessment is that in October 2015 we went live with what's called Care Partner. So actually across the whole of our adult services, so that incorporates all older adult services, it does also incorporate some areas of children's, so CAMS in particular. But there is a single electronic assessment record system that is now in place. And that's really important because before we would have different services developing their own assessment tools. And actually what would often happen is that people would require different services because nobody comes with just one need. And then we'd often end up having to go through a whole range of assessments, often asking the same questions. So what we have today is one single assessment tool that has the ability to attach to it some specialist assessments that just feed that system. It should reduce the numbers of times we're asking key questions. And I think evidence shows that that is beginning to work. The second thing that happened more recently is that back in April 2016, just last year, we actually did a fairly wholesale move for quite a number of our services into a new location. So we moved into Eagle House, which is on Columbury. And this is quite important really, because what we've actually done is to target a significant number of our adult services that were all located in different settings into an integrated setting. Now it isn't everything as yet, but it's a really significant start. I have got some handouts and this will go out with the minutes anyway, so apologies if it comes out quite small on here. Just to give you an indication of the services that we've brought together so far in an integrated fashion. Includes both adult and older adult social work services, which are now fully integrated. We've got our continuing care nurse team, we have the learning disability team, the autism team, we have a positive behaviour support service in there. We have what's referred to as the alcohol pathway, which is some new investment that came out of the white paper over the last couple of years. We have our older adult mental health service, we have adult safeguarding, and then we've also got our community and social services senior management team, all co-located within Eagle House. And the reason that this is important is that because when an adult requires services, what's really important is that we're in a position to start wrapping the service around the person and not an individual having to access half a dozen different services. And if I refer to having moved into Eagle House, one of the things that has improved significantly since we've been in there is the development of what we call a single point of referral. the sport. Now, we talked about this. The whole concept of this has been on the table for a number of years. I was really pleased to be able to stand up and say, actually, we've made really good progress on this now, rather than it just being our vision. There's a reality to this, and I know I've talked to a number of people over the years about what we're trying to achieve, and we have made really good progress with this. Now, the thing that's important about the SPORE, the single point of referral, that's our front door. Now, if I'm being honest, it isn't quite the single point of referral yet. So if I go back 2-3 years, we had 16 front doors into services. Yes, no wonder there's a gas. But it's no wonder where people find it really hard navigating their way to the right places. And often what would happen is somebody would come in the front door and it's the wrong bit. And they'd say, it's not us, it's them over there. So somebody would have to come out and go back in through another front door, often having answered quite a lot of questions before we get there. What we have now is, we are down from 16, there are 5 front doors left. It is our intention to have 1. And it is our intention within the next 12 months that we have, based on what we've established at Eagle House, that there will be 1 front door with 1 contact, 44440, nice easy number to remember, with 1 email contact as well, but also with the ability to actually walk in the front door and drop in. So our expectation is to have a single point for people to be able to get the information that they require if somebody needs access to community-based health or social care. We've also, something that's really important, developed, if you like, new working practice. And this is important from the carer's point of view. I'll come on to the carers. So, in that most of our work is actually out in community. It's often in people's homes, because that's where we will meet people and undertake the assessments that we need to do in order to establish the support that an individual requires. So what we have now is all of our frontline practitioners actually work in this, what we refer to as a flexible and remote way. And we've been able to set people up with the tools they need. But very simply, that is, that everybody now works off a laptop. Now that might not be any surprise in the 21st century. It is for social workers. But actually what happens is, we are able to, in setting up Care Partner, people can actually access that single integrated assessment remotely now. So we can actually do it from people's homes, we can do it from any care setting, and that's really important because, as I say, most of the work is out there with people. So if you bear in mind that historically we might meet somebody and then go back to the office to write up the assessment, actually sometimes that still happens, but actually there's much more creativity, flexibility in how we undertake those assessments. And there's much more opportunity from an individual who actually needs services and for carers, to be able to contribute to that assessment process. Because actually you can do it in your front room. You can actually assist in completing that whole assessment process. So it's a very different model, a much more engaging model that we're aiming to achieve. And again, I'm not going to stand here and pretend that we've got this all right yet. This is less than 12 months that we've been operating in terms of the new model, but it's certainly significantly better already in terms of the impact. So that's really important to understand, because the assessment framework that we have in place actually includes the opportunity to talk about carers' needs within that. And there's something really important, which is when we do an assessment for an individual, it isn't just about the individual's needs. If there are carers involved, that has to be integral to that assessment. And the assessment produces what's called a personal support plan. And actually that personal support plan must also reflect what are the carers' needs through that, in order to put a truly holistic care plan together that captures the whole thing, because the essence of what we're doing is about enabling people to remain at home. That's it. Whatever the level of need, our ambition is that we understand and can respond and put support in place that enables people to remain living at home with their loved ones until such time individuals might choose to move on or change those arrangements. Again, I'm sorry this is small. There are copies, some copies at the front, which I'll leave if people want to take, and it will come out with the minutes. But I did want to take the opportunity to share with you some of the further changes that are now going to be taking place over the next 12-15 months. We're embarking on a fairly ambitious programme of change across community and social services that further impacts and improves this notion of where we have segregated teams. And very simply, at the moment, out there, under my remit as a Director of Adult Services, I might have the Adult Mental Health team, I might have the Adult Social Work team, the Learning Disability team, the Autism team, the Drug and Alcohol Service. So even though we're pulling it together, there's still silos within the way that we're operating. And again, it's our ambition to try and ensure that we develop systems that mean when somebody comes through the front door, actually we wrap the team around the person, not the person having to access several teams. So please stop me if I get jargonistic or confusing at all. What is the bit that's important from my point of view is that my services will change. Because what we're introducing is a change in here, but instead of adult services, we're actually talking about community care and health services. And in there we want to develop what we call reception and protection services. How do you get in a single front door? And actually at that front door, how do we make sure we've got the right services to respond to any crisis that's required? Because there's two levels of things that we generally do. One is sometimes people are in crisis and we need to act immediately. What is it that we can do quickly, succinctly, in order to help somebody stop being in crisis? The majority of our work is planned. It's a planned referral that comes through, and we can take our time to work with individuals and families in order to put into place the right support. And inside, and again this slide is even worse, so bear with me. Inside, sorry, if I just go back to here, everything at the front door, reception and protection, and then inside we've got what's referred to as assessment and care management. And that's where, in the essence, in terms of a carer's need, this is where the response needs to be from. So in there will be, instead of a mental health team, a social work team, a learning disability team, in there will be 4 fully integrated assessment and care management teams. Now, there's another piece of work that's going on that's important to understand, and it's the primary care strategy, the work that's going on through our commissioners in health and social services have been working with all our colleagues in primary care. But from a GP perspective, there's this vision of clustering to 4 clusters of GP practices. Now, the reason that's important to us is we're looking at, coincidentally, 4 integrated teams. So this is just an example. So please, when you take this and you receive it, don't take this as a given that this is the final product. This is just an example of how it might look. And we're actually doing some work now. We will be engaging with partners as well to be looking at how we form and develop these integrated teams. That's why it's going to take us probably the next 12 to 15 months from concept to actually implementing. Because at the moment, all these people sit in different teams. But to give you an idea, what we've got in there is a range of social workers, we've got psychiatric social workers, learning disability nurses, community psychiatric nurses, We've got primary mental health support workers, we've got occupational therapists, we've got community detox nurses. So there's a whole cluster of, so the concept is, when somebody comes through the front door, actually the reason that they will go to this team is not because they need the adult mental health team or they need the learning disability team. It will be because of who your GP is. Because our expectation is that this team will form an active working relationship with that cluster of GPs, so that we're actually working much closer, hand in hand, from the primary care to some of the secondary care services that we provide. So that's our ambition. So we've already brought in the IT system to improve our assessments. We've already integrated a number of services into Eagle House, developed some new ways of working that enables for flexible and remote working. And then our next ambition is that we are looking to ambitiously change the model of community and social services and develop a range of truly integrated teams, so that when an individual comes through, depending on what your need is, the team will be formed by a number of these individuals, rather than coming into different teams.
So Chris, will there be 4, or is it just